Just a minute. Some issue with my screen. Yeah, sorry. Just a minute. Sorry, guys. Sorry for the delay. Yeah. So we are talking about glomerulonephritis, and we are going to start with the basic pathophysiology of glomerulonephritis. So that once we end up understanding this pathophysiology, we will be able to understand the rest of the things very well, right? Yes. So I hope now everything is all. Guys, sorry for the delay. Yeah. So we are talking about glomerulonephritis. Yeah. So let me move on to the basic understanding first. So look at the basic understanding what I want to discuss here. So in this basic, first let us talk about the cross section of the glomerulus. So how does a glomerulus appear to us? And that is what I am interested in first. So cross section of the glomerulus. Yes. Yeah. So let me move on to. Yeah. So look at this. This is the cross section of the glomerulus that I am showing you guys now. So what you are seeing in this cross section of the glomerulus, I have cut the glomerulus here. This is your mesangium of the glomerulus, and these are your capillary loops, isn't it? These are your capillary loops. You can see a beautiful RBC within this, right? This is a RBC within it, and these are your, anybody remembers? These are your foot-like processes coming, and this cell will be what? Epithelial cell, isn't it? Which epithelial cell is it? It is towards the inner aspect. That is why this will be called as what? Visceral epithelial cell. This is your visceral epithelial cell. Now, next is on the other side. Look at this. After the visceral epithelial cell, you are having what? Empty space. This is your urinary space, and this urinary space is peripherally lined by, this is another epithelial cell. Can you tell me? This another epithelial cell is the parietal epithelium. Yes, correct. Very good. I like your answer, guys. This, which is having a foot-like processes, this is also called as a podocyte. So your visceral epithelial cell is nothing but your podocyte. Very good, podocyte. Now let us start talking about the physiology of the filtration. Basically, in the glomerulus, what is going to happen? Filtration is going to happen. We all know that point. So let me talk about physiology of the glomerulus. What is exactly going to happen? The blood is going to come into the capillary loops, and in the capillary, you can see these are your endothelium of the capillary is having multiple holes. Anybody, what are these multiple holes? Multiple holes will be the fenestrations. Yes, these are your fenestrations that are there, and these fenestrations, so what happens is blood comes into your glomeruli. Through these multiple fenestrae, the blood gets filtered. It is just like your, if you are a South Indian, I would say this is like your filter coffee of the filter, or if you are a chai lover, it is like a chai ki chalni jo hai na, वैसे है. So you pour everything, either tea or coffee, all your what? The larger particles stay back and the smaller particle get filtered out. Simple understanding. Yes. So the larger particles stay back, including your cells of the blood will stay back in the capillary, and also the larger proteins like albumin stay back, and this globulin stays back, and the smaller things like water and the dissolved substances like what? maybe everything else, whatever is dissolved in the water, they get filtered out, and once they are getting filtered out, they will accumulate in your urinary space. This is your Bowman space or a urinary space. Ultimately, what will happen to your urinary space? Urinary space will form the tubules, isn't it? Now let me talk about, these are your food processes. Yes, correct. So there is this food processes which are embedded into the basement membrane of your endothelium, and because of this embedding into the basement membrane of the endothelium, there will be a net negative charge created to your filtration. So your filtration barrier is a dual barrier. It is not as simple as your what chai ki chalni ya filter of the filter coffee. It is charged chai ki chalni or charged filter coffee machine, you can, or filter. So basically, what is there? There is one size-based filtration happening. The larger things don't get filtered out, correct? Smaller things definitely get filtered out. But however, since there is a net negative charge to your filtration apparatus, because there is a net negative charge in the filtration apparatus, this will lead to repulsion of the negatively charged substances in the blood. So very, very important, what physiologically, what do not get filtered in the from the blood into the urine, all large things do not get filtered, and also whatever are negatively charged do not get filtered. The net negative charge is due to multiple factors, by the way. One predominant is your food processes which are getting embedded into the basement membrane. The basement membrane itself, because actually this is what, okay, I'll come to that part later. So it is predominantly because of the filtration slit proteins, we call them, the net negative charge. But the negative charge is to the basement membrane only. But it is coming because primarily from the proteins of your podocytes. Because the proteins are getting what, or the food process are getting embedded, that is creating that negative charge. So I hope all of you are now understanding. So two things. Now let me try to convert this into electron microscopy. Now let us look at the electron microscopic image as well. So let me try to look at the electron microscopy, and people get confused in electron microscopy. That is why I am showing you this. Let me see. Let me try to see how many of you can correlate now. I am zooming it so that you can understand it very well. Look at this now. Are you seeing food processes in this image? Tell me now. Are you seeing food processes in this image? Answer absolutely yes, I am seeing food processes. Can you tell me these are your what? Food processes. Are you seeing the food processes here? Yes, these are the food processes. That means this will be your, this cell will be your what? Podocyte or a visceral epithelial cell, isn't it? Yes, visceral epithelial cell, this will be. And on the other side, obviously this will be your what? Lumen of the vessel, and this is the endothelium. So what I can see in the endothelium, now I am zooming it further so that you can understand. So look at the endothelium. It is not continuous. It is what? Discontinuous line, dot, 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 dot. You can see beautifully here. It is not continuous, the endothelium, dot, dot. This is your fenestrated endothelium. And in between these two, look at this, in between these two, you are seeing a line here. This line that I am talking, that is your basement membrane. That is your basement membrane. So very, very important orientation, identifying in electron microscopy. You need to know which is the endothelial side, which is the epithelial side. Usually I would like to look at what? Podocyte. But problem in some diseases, the podocytes will be what? Effaced. And that is the reason why you need to also know the endothelial side as well. Okay. Yes. So endothelial side and the epithelial side of the basement membrane, we call it, right? Now, let me just try to explain you, enlarge this filtration barrier and understand little bit more of the filtration barrier then. So what is a filtration barrier? So filtration barrier is nothing but your what? Basically your endothelium and your what? So look at this. This is your filtration barrier I am trying to show. So what is there in this filtration barrier? So look at this filtration barrier. Again, this is the zoomed version I am showing. Let me see, zoomed version here. Okay, again, can you identify which side is what side here? So tell me which side is the endothelial side and which is the epithelial side here. Anybody? Can you identify which is the endothelial side, which is the epithelial side? I just want to identify the endothelial and the epithelial, nothing more in this. Yes, simple. On the top, north pole is your which side? Endothelial or epithelial? That is the north pole that is seen here, that is your endothelial. Yes, upper is the endothelium. Very good. And the lower is the epithelial side. You can see these are the food processes. Now look, very important, in between these food processes, whatever spaces they are there, these are called filtration slit. These are your filtration slits, and these filtration slits have many proteins like podosin, then alpha 4 actinin, nephrin. These are the proteins that they are there on your what, lining the filtration slit. And this filtration slit proteins, which are these are the one which give the net negative charge to your what, filtration barrier. So rather than using just basement membrane, better I will use what, functionally I can use the word filtration barrier, because basement membrane is only this much, right? The whole thing will be called together as what, filtration barrier, because this is a physiological unit, it's not an anatomic. Anatomically endothelium is separate, basement membrane is separate, and your podocytes are separate, right? Anatomically they are separate. Better let me call physiological one unit, that is your what, filtration barrier. So in this filtration barrier, there are fenestrations that are there, that is your size base, that is taking care of size base filtration. And then there is a net negative charge, that is taking care of charge based filtration. And also I want you to identify basement membrane. How to identify basement membrane? Many a times, as I said, because of deposits, you will not be able to identify what, the epithelial side. Then you are relying on what, endothelium. Many a times you will not even be able to identify endothelium as well. Then I have to always keep looking for basement membrane. So in the basement membrane, so look at this is the rough image also. Let me try to draw. In the basement membrane, you are having, let me try to draw, look at this. I am just trying to draw the same thing here. These are your what, food processes. This will be your what, filtration slit. This is your basement membrane. Basement membrane, I have drawn two yellow and one dark. You can see this very clearly here. What is that? One dark line is seen in the center, and on either side it is two light or faint lines that are seen. So these are accordingly called, there are three layers for your, three layers are there for your what, endothelium in the capillary. That is your lamina densa. Anybody, what will be lamina densa? Lamina densa will be the one which is denser. The central one, lamina densa, we say lamina densa is sandwiched in between your two lamina. Whatever is not dense, that is called rare, lamina rara, isn't it? So there are two lamina raras. Anybody now, can you tell me what are these two lamina raras? One will be called a lamina rara interna, another will be called lamina rara externa, isn't it? Yes, lamina rara, which will be interna, towards the endothelium, isn't it? Yeah, towards the endothelium will be what? Yeah, so this is your lamina rara externa and interna. So one is towards the endothelium, that is interna, and the outward is the externa. Okay, this is the anatomy that I was talking about. This is the anatomy of your filtration slit, isn't it? Or the filtration slit barrier. Now let us talk about our filtration barrier. Now what is happening with the filtration? Let us talk about a little bit more of physiology now. Physiologically, what is happening? Physiologically important, the fenestrated endothelium that is there. This fenestrated endothelium, yes, there will be pores. Size is roughly 70 to 100 nanometers. So now size not important for me. Yes, it is I mean just a fact oriented, and this takes part in size based filtration. What do you mean by size based filtration? Already we discussed, anything that is larger will not get filtered. Like what? Yes, correct. Any basement membrane will have lamina densa like that. Okay, yes. So basically you are having one, there will be size based filtration is by what? Fenestrated endothelium. Now similarly, there is the basement membrane. The basement membrane that is there is composed of collagen. Collagen, which collagen? Type 4 collagen is there. Then it is also made up of laminin and many other proteins. So the other proteins that I am talking, so what is happening is, and then there is what? Filtration slits also are there. So these filtration slits also have what? Many proteins. Like what? Nephrin, podosin, alpha actinin, so many are there. Yes, so basically you are having, yes, filtration slits are there. So like nephrin, podosin are there, and also the visceral epithelial cells, which are having these food processes which are embedded into what? The basement membrane, we said. And this formation of a filtration slits is there, right? So now Together, all this is giving rise to what? Negative charge, we say. Not only that, one more, there will also be what? Yes, so together this is giving rise to what? Negative charge that is there. So the negative charge is a complex thing to explain. It is still not fully understood physiologically. It has been explained by the collagen itself can give rise to negative charge. More important are the filtration slit proteins. Pathologically, this is more important. Why? Because whenever there is effacement of food processes, filtration slit protein will be lost, and that is why negative charge will be lost. Pathologically, this is very important. And second and the third are what? Very related to each other, isn't it? Yes. So the net negative charge that we are talking is due to what? This. Now, then there is, okay, we'll come to that part. Then still we are talking about what? Some physiology and anatomy. Mesangial cell. Mesangial cells are the supporting cells, and they are capable of synthesis of what? Matrix, collagen, contractile function also it has, and phagocytic. Basically, mesangial are your monocyte macrophage derived cells, which are what? Supporting cells to the glomerulus. So they have multiple functions. So if there is a repeated injury happening to the glomerulus, there will be collagen synthesis. That is by what? Mesangial cells, like that. Okay, yes. So this is your basic understanding of the microanatomy and some physiology of glomerulus. So we were discussing what about the filtration. Yes, filtration barrier. Filtration barrier I spoke about is made up of what? Two things. One is a size based filtration and another is a charge based filtration. So size based filtration is due to filtration slit and fenestrae also. Fenestrae primarily, small amount is by filtration slit. Charge based filtration is by GBM. The glomerular basement membrane has a net negative charge. So it is because of multiple things like basement membrane, slit proteins, and many other things like podocytes. They will play an important role in having a negative charge. So very, very important. Thus, what is happening physiologically? Physiologically, larger molecules like what? Blood cells, RBCs, or cells, you can say WBCs, RBCs, globulins, and WBCs. They do not get excreted in urine. Why they do not get excreted in urine? Obvious logic. Their size is small or large. Large. They are large. They will not be what? Filtered out. And that is the reason why they are not filtered physiologically. Next, on the contrary, important, another, any anionic molecule. What are anionic molecules? Anionic molecules are also, which are negatively charged, are also not excreted. Why are they not excreted? Because negative charge is there for the filtration barrier, isn't it? Although theoretically we call basement membrane is net negative charge, better we call it what? Filtration. Rather than using anatomical, we use the word physiological unit, right? Filtration barrier, which contains basement membrane, filtration slit protein, podocytes also, right? Or the food processes as well, right? Yes, like albumin, antithrombin. These are not normally filtered. They are physiologically not filtered by kidney, isn't it? Now, so this is your basic physiology I wanted to talk about. Now let me convert this physiology into a pathophysiology. Let us see now what is the pathophysiology that is happening here. So let me convert this physiology into pathophysiology. So in this pathophysiology, I want to talk about what happens now. So we are talking glomerulonephritis. Anybody remember what is itis? Pathologically, itis is inflammation. Glomerulonephritis is inflammation of glomeruli. And we all studied, let me brush up your inflammation. Inflammation is specific or non-specific? It is a non-specific. When it is non-specific, will it only damage the agent that is there, or will it also damage your normal structures? It will also damage the normal structures. So now if it is going to damage normal structure, it can damage two things. One, it can damage your what? Charge based. Functionally we are talking, it can damage your charge based filtration, or it can damage your size based filtration, or both of them as well. I hope all of you can understand. So glomerulonephritis, let me talk about glomerulonephritis. Most of the glomerulonephritis are immune mediated injuries. Most of the glomerulonephritis are immune mediated. We all know this. So immune mediated, if not all, most of them, right? So few of them might not be, but mostly what we see clinically are all one immune mediated glomerulonephritis. So these immune mediated injuries could be by one, antibodies can be there against part of the glomerulus. So there can be, it is a type 2 hypersensitivity. There can be antibodies against any part of your glomerulus. Example, good pasture syndrome. Anybody knows what is good pasture syndrome? Tell me now. Good pasture is a type 2 hypersensitivity, and there are antibodies against what? Yes, there are antibodies against what? Antibodies against the basement membrane, glomerular basement membrane. Next is one more, in situ immune complex deposit. What is in situ immune complex? See, we studied this in general pathology. There are two types of immune complexes, circulating immune complex and an in situ immune complex. A circulating immune complex, the immune complex will be formed in the circulation and it gets deposited into various tissue. Like it can get deposited in glomeruli, skin, lungs, and that is why circulating immune complex disease will have a generalized manifestation. So in a circulating immune complex, glomerulonephritis is one of the manifestation of the disease, of the whole spectrum of the disease, right? That is a circulating immune complex. What is an in situ immune complex? Tell me now. In an in situ immune complex, the immune complex formation happens in the kidney only, that is in the site. Like take PSGN is an example. Let me explain you PSGN, post streptococcal glomerulonephritis. Patient has an infection by streptococcus either in the skin or in the throat, pharyngitis. Then what? Streptococcus produces some proteins, antigens, SPEB we call it, and it keeps secreting these proteins, and after 1 week, your body will take minimum 1 week to form what? Immune response. And after 1 week, when you have an immune response ready, by that time your antigen from the sore site, that is from the sore throat or from the skin, already has gone into the circulation. From the circulation, it has got deposited in the kidney. So why will that antigen get deposited in the kidney? Obviously, now we can understand kidney is having what? Charge which can attract it, isn't it? And that is why it could be getting deposited in the kidney. Antigen has already got deposited in the kidney. After 1 week, you produce an antibody. The antibody goes and binds to the antigen, and antigen is present in the kidney. This is called in situ immune complex. So remember, in situ immune complexes will be only localized diseases. Yes, correct. They will be localized diseases. On the contrary, circulating will be generalized. Okay. Yes, in situ immune complex formation. So in this example, antibodies in the circulation bind to an antigen in the kidney. We understand, in the glomerulus, better word. Now, so these antigens in the glomerulus could be two types of antigen. One, either it is an intrinsic antigen. What is an intrinsic antigen? Say suppose like, okay, I'll not give you diseases as of now. Suppose there is an antigen in your kidney only, and that has, or within your, from within your body. The antigen from within your body has got deposited in what? Mesangium or kidney, anywhere. And then what? That antibody against that will end up what? Forming an immune complex. The classical example, intrinsic antigen, will be an IgA nephropathy. In IgA nephropathy, the IgA that is produced is aberrantly glycated IgA. Because aberrantly glycated IgA, it becomes an antigenic stimulus. So thus you are recognizing this aberrantly glycated IgA as non-self, isn't it? And this IgA is getting deposited in the mesangium. And once that gets deposited in the mesangium, you produce an antibody against the IgA, and this will form an immune complex only in your what? Mesangium. In contrast, since I have taken IgA nephropathy, similar IgA nephropathy, I will tell you one more disease, HSP. HSP also, there is an aberrantly glycated IgA, similar pathogenesis. Only difference is, in HSP, the immune complexes are formed in the circulation itself. What is HSP? Henoch-Schönlein purpura. Immune complexes are formed inside the circulation. Because immune complexes are formed in the circulation, can you tell me now, HSP will have what? Generalized manifestation. Like there will be purpura, petechate, joint pain, arthralgia will be there, abdominal cramps will be there, and glomerulonephritis will be there. So in a circulating, glomerulonephritis is one of the manifestation. So, or extrinsic antigen is deposited, like we discussed just now in PSGN. In PSGN, extrinsic antigen, streptococcal antigen got deposited in the kidney. And usually when it is an extrinsic antigen, remember, recurrence chances will be less. Here only you will understand. Obviously, if the antigen has to come from outside, if I have to recur the disease, subsequent time also I should have adequate number of what? Antigen, isn't it? If it is an intrinsic antigen, it will be abundantly present in the body. That is why it can keep what? Recurring, like IgA nephropathy recurs. PSGN doesn't recur, isn't it? Yes. So Look at, and that is why I keep saying this. For glomerulonephritis, pathophysiology. You understand pathophysiology? Everything in the disease falls into its own. You need not mug up anything here. Okay. Yes. So now we can understand. Questions already have come. HSP, IgA nephropathy. How do you differentiate? You should know. IgA nephropathy, PSGN. How do you differentiate? You should know. Okay. Next. So these extrinsic antigen, we also call them as a planted antigens. These are called planted antigens, obviously, because they are planted from outside, isn't it? Yes. So this will be for immune complex. Then one more, there can, okay, once there is the what you call antigen antibody complex, fixation of complement will happen, death of cells will happen, MAC will be formed and death of the cells. So which cells will die? Some of the cells in the glomeruli, either podocytes die or endothelial. There are two cells that I am talking about, either podocytes or endothelial cells keep what? Dying. Simple understanding. Right? Next, circulating immune complex. What about circulating immune complex? Circulating immune complexes, yes, these will be what? These will be large immune complexes that will be formed. So these many immune complexes which are there in the circulation can get deposited in the kidney. Understandably, they can get deposited in the kidney or in the glomerulus, better word, due to their two things. One, hemodynamic and physicochemical characters. Due to the hemodynamics and physicochemical. Hemodynamics, because in the glomeruli the blood flow becomes very, very slow. That is why anything is more likely to get deposited in the glomeruli, or in fact in capillaries. Any capillary, the blood flow becomes very, very slow. That is why your immune complexes tend to deposit mostly in what? Capillaries, right? So any organ which is rich in capillary, yes, any organ that is rich in capillary can have these immune complex deposits, mostly glomeruli and lungs, skin, etc. So now size and charge. So basically the physicochemical characteristics I am talking is the size and the charge of the immune complex decides where these will be deposited. So very important. So size of the size and charge of the immune complex will decide where it will be deposited, or it will also be based on what? If it is an implanted antigen, it will be based on the size and charge of the antigen itself. Now you have to understand one more fact here. See, this is a very dynamic thing. Sometimes what will happen is the antigen would have got deposited in what? Subendothelially. But once the antibody binds, an implanted antigen is subendothelially. Once the antibody binds, damage starts happening. The charge might change and they get repelled from the endothelium, or they get pulled towards the epithelium also. So this is a very dynamic thing. So sometimes there will be what? Initially the disease begins with subendothelial and then can go into what? Subepithelial as well. Anybody knows which disease happens like this? This can come as a question. Which disease begins with subendothelial pathology, progresses to subepithelial? Anybody knows that? Anybody knows? Anybody knows which one is that I am talking about? Yes. That is your PSGN actually. Okay, in PSGN, this is what happens. Okay, now let us talk about the size and the charge. Size and the charge, let me talk about highly cationic. What are highly cationic? Cationic will be what? Positively charged. So if cationic are positively charged, what is your charge of the filtration barrier? Filtration barrier will be negatively charged. So if it is, that means, and also I told you filtration barrier gets negative charge predominantly because of filtration slit proteins, isn't it? Yes. So highly cationic charge, which are positively charged, they will get attracted towards your what? Filtration slit. So they will cross the basement membrane and get deposited where? Subepithelially we call it. So what is a subepithelium? Let me try to depict a reference here. So look, I'm trying to show, these are your what? Capillary. I hope all of you are able to see these are the capillary, and the same thing, these are your what? Podocytes, and this is your what? Food processes, and the red line is your what? Basement membrane, and this is the mesangium, right? Yes. So now let me just try to show, this is your what? Podocyte, epithelial cell. Yes, correct. These are podocyte. This will be your one. Dark layer is lamina densa. Look at this. This is your fenestrated endothelium. This will be lamina rara externa, lamina rara interna, right? So now what happens is anything which is positively charged. So the blood is coming. This is the blood, by the way. Okay, it has become ulta, but anyway, I can explain it. The blood is coming here. If it is positively charged, look at this. Your filtration slits are what? Negatively charged. Immediately they attract your immune complexes. Because they attract your immune complexes, these immune complexes go and get deposited here. And when they get deposited here, we start calling them as subepithelial. So these are called subepithelial deposits, right? Subepithelial. Can we use plasmapheresis to manage these conditions? It depends. Like in a good pasture syndrome, it can help because it is an antibody mediated. In other immune complex mediated, immune complexes already are deposited in the kidney. Plasmapheresis will not be helping you much. Why? Whatever has got deposited in the kidney, that has to cause injury, right? Okay, so basically your highly cationic or positive charge get deposited subepithelially. Next, second, what will happen if it is highly anionic? Highly anionic means highly negative charge. If it is a highly negative charge, then what will happen? So highly negative charge and also large immune complexes. If it is very large also, anything which is large cannot easily reach what? On the other side, cannot cross the basement membrane. So these cannot cross basement membrane, thus get deposited in subendothelial region. So what is the subendothelial region? So look at this. This is number 2 that we are talking. So they are getting deposited what? Subendothelially. The immune complexes are getting deposited subendothelially. If they are what? Anionic. Obviously, they will be repelled by your what? They will be repelled by your negative charge of the filtration slit, isn't it? They'll be repelled by negative charge. Okay, repeat it again. Anything which is positively charged. We discussed there is a size-based filtration and a charge-based filtration. Your basement membrane, glomerular basement membrane is negative charge because primarily I told you because of what? Filtration slit proteins and also partly basement membrane itself. Now, so which is negative charge? If it is a positively charged, easily gets attracted towards what? Towards the filtration slit. And if they get attracted towards the filtration slit, look at this. These are your filtration slit and this is your endothelium. Actually, you should have shown ulta because when we saw it was ulta there. So they get, this is the blood. Blood will go and immune complexes go towards what? Epithelium, because here it is negatively charged, isn't it? So let me write, this is your negative charge, by the way, right? Next is what will happen if it is a neutral charge. Neutral charge or neutral molecules, they tend to deposit in the mesangium. So they tend to deposit in the mesangium. Okay, yes. So this is your basic understanding. Now, so let me try to extend this into investigation. So what investigation do we do for glomerulonephritis? One of the investigation that we do for glomerulonephritis is immunofluorescence. And we need to understand immunofluorescence with respect to immune complexes or antibodies. Then we'll understand it better. So what is immunofluorescence in renal biopsy? So immunofluorescence is nothing but it is a way to detect what? Immunoglobulins or complements that are deposited. See, because so many of them are immune complex mediated diseases, we want to detect these antibodies. Where are they deposited? Which complement is deposited? Where is it deposited? Everything. So how do I detect this? For this immunofluorescence, there will be fluorescent labeled antibodies to the immunoglobulins and the complements will be used. So we are going to use and we are going to detect antibodies that are already deposited in the kidney. So this is an indirect IF that we are doing. This is an indirect IF that we are doing. So in the tissue, we are detecting antibodies that are already deposited or complement that are already deposited. So what we'll do is we will have antibody against IgG, antibody against IgM. So I'll have an anti-IgG, anti-IgM, anti-IgA, anti-C3, anti-C4, anti-C1, etc. So I will have antibodies against what? All the known complement protein that can be deposited in the kidney and all the known antibodies that can be deposited in kidney. And each one of these will be tagged with a fluorescent dye, will be attached with the fluorescent dye. So what do I do now? So let me take, if there is an anti-GBM antibody disease. Tell me now, what is anti-GBM antibody? We said good pasture syndrome. Now tell me, in a good pasture syndrome, what will be happening? Let me try to explain the pathology of good pasture syndrome, and then we'll understand IF also. There are antibodies against the basement membrane. So look, this red is your what? Basement membrane. So antibodies would have bound to what? Basement membrane, isn't it? These are the green ones, which are the antibodies. These are the pathological antibodies. Remember, these are bound to what? Basement membrane already, isn't it? Now, I want to detect these antibodies. That is what is my indirect IF here. So now, if I want to detect these antibodies, how do I detect these antibodies? Okay, so let me say this is IgG. If these are IgG, do I have an anti-IgG? Answer is yes, I have an anti-IgG. And now this anti-IgG is already tagged with a fluorescent dye, isn't it? So I am going to add this anti-IgG now. So this anti-IgG, the purple one, look at this. These are anti-IgGs I am adding, and these will be what? Will be fluorescent labeled antibodies. I hope all of you are understanding this. These are the fluorescent labeled antibodies, meaning what? They will emit a fluorescent light. They will emit a fluorescent light. This is an indirect IF, isn't it? So once they emit a fluorescent light, now what will happen is, in a fluorescent, when I observe them under fluorescent microscopy, the normal visible light doesn't come in. We have blocked the visible light. That is why the background appears what? Black color like this. No visible light, only fluorescent light will be seen. Now, what will happen is, since the glomerular basement membrane will be linear, isn't it? Basement membrane will be in a line, isn't it? Because it is in a line, your pathological antibodies, anti-GBM antibodies also would have bound in a line. So, the green one is anti-GBM antibodies here, and the purple ones are what? The antibodies that you have produced. These are your test antibodies, isn't it? So, you will end up getting a pattern like this. That is your what? Line like pattern. Why line like pattern? Because this is how exactly is your what? Basement membrane, isn't it? This is how your basement membrane, and this is what we call a linear pattern. So very, very important, linear pattern, if you are seeing, it indicates there are what? There is whatever deposit has happened is along the basement membrane. Okay, that is called a linear pattern. Why do you get linear pattern? Because antibodies will be so many antibodies close to each other. Two fluorescent lights will fuse with each other, forming a single line. I hope all of you are understanding this linear pattern. Now, similarly, imagine if there were immune complexes. Let me try to explain. If there were immune complexes, let us say here immune complexes are there. Immune complexes will not be like a continuous line like what was there in anti-GBM, because they get deposited haphazardly. There will be some deposits here, in between no deposits, again there will be more deposit, because immune complexes deposition is based on size and charge. So everywhere same amount of deposit will not happen. Somewhere there will be no deposits in, sometimes there will be more deposits, some places there will be what? Less deposits, like that. So look at this, some deposits are more, some deposits are less, like this. And because you are having such a deposit, so your fluorescent labeled, now these immune complexes will also have antibody. Let me say IgG antibody immune complex was there, and now what will I see? I will be seeing, yes, now if these are the antibodies, and then what? I am having what? My antibodies. The purple ones are the test antibodies. So instead of appearing like a line, they will appear like what? Multiple dots will be seen. You can see that. I can still see it is what? Not like exactly like a line, but there is a dotted line that you are seeing. This dotted line, because these immune complexes have got deposited along the basement membrane only somewhere, either on the endothelial side or the epithelial side. I will not be able to distinguish. This is what I will call it as a linear pattern. This is your, this is your granular pattern. Sorry. So you are seeing a granular pattern. Sometimes immune complexes. So very important, granular pattern tells me it is an immune complex disease. It doesn't tell me, you cannot identify subepithelial, subendothelial on what? IF. It tells me it is one immune complex mediated. Linear tells me it is an anti-GBM mediated or antibody mediated, only one disease in kidney. Next, one more, there could be deposits in the mesangium. The neutral particles, neutral complexes gets deposited in the mesangium. So what will I see? I will see only the mesangium will highlight, the rest of the glomeruli will not highlight. So this is how it will be seen. So mesangium, which will be in the center, that will highlight. Let me try to show you. Surrounding the mesangium, there would have been what? These are your what? Capillary loops. I am showing these blue ones. They will not be highlighted, by the way. I'm just trying to make you understand. So this will be your what? Capillary loop. That will not be highlighted, but the mesangium gets highlighted. That is your mesangial deposit. Mesangial deposit, right? Okay, so now can you try to identify what pattern am I showing? Two images here. Try to identify what are these two images on the left hand side. What you are seeing on the left hand side, let me try to help you out how to interpret this. This is actually the blue line. Focus on the blue line. This blue line that I am drawing, this is whole of your what? Glomerulus. This is your glomerulus, and this inside what you are seeing, these are your what? Linear deposit. Yes, correct. One is a linear. This is not wire loop. Wire loop will be seen on light microscopy, not on IF. This is a linear deposit, line like deposit, linear. Now look at this. So why line like? Look at this. Basically, these are actually, I hope all of you are able to see in the center. This is your what? Okay, let me try to show you. Capillary lumen. This empty structure will be what? Lumen of the capillary, and whatever painting has happened, that will be why? Basement membrane, isn't it? This is what is your, yeah, this is your linear deposit. And look at this, the second one. Again, this whole structure, let me draw this blue line, the dotted blue line that I am showing, imaginary one. This is your what? Glomerulus. This whole thing is the glomerulus. And again, look at the arrow mark that I am pointing. Can you identify what is the arrow mark pointed towards? These are not deposits, it is empty. Tell me now, what is it? This will be what? Lumen of the capillary, isn't it? Around the lumen, I am seeing what? Deposits again. And look at the difference between the deposit here and here. Here, it is not a continuous line, isn't it? This is called as a granular deposit. And where do you get a granular deposit? Granular deposit are seen in immune complex. So if I see a granular deposit, I can think there are immune complex deposits happening, and because they are happening along the basement membrane, so these immune complexes are either deposited subendothelially or subepithelially, isn't it? That is what I'll be thinking of. Next is, let me move on to, now this was the pathology. Now let us move on to the convert this pathophysiology into clinical features. See, ultimately, any of the immune complexes, we said they will get deposited where? Either subendothelially or subepithelially or what? Mesangium, isn't it? Now, so let me talk about where will they get deposited. So if they get deposited in subendothelially, there will be immune complex deposition and there will be complement activation. Complement will damage the endothelium. Now, if there is a mesangial deposit, damage will happen to the mesangium. See, mesangial deposit happens, the glomeruli start collapsing because mesangial's function was to support your glomerulus. So, let me take together, if there is a damage to the endothelium and what, or mesangium, what will happen? Endothelial damage or a mesangial damage, what will happen? Yes, sir. Tell me now. If endothelium gets damaged or a mesangium, obviously endothelial damage will happen whenever there are immune complexes are deposited subendothelially. Now, and there will be what? Mesangial damage if there are immune complexes depositing in the mesangium. So now, once there is endothelial damage, endothelium gets damaged, fenestrae will be what? Bigger now, or fenestrae will be damaged. Because of that, the holes become bigger. So larger structures getting filtered out. So first thing, before that, if there is a damage to the endothelium, vascular response to the endothelial damage is vasoconstriction. So whenever there is endothelial damage, obviously you don't want to lose blood, and that is why you want to first do what? Vasoconstriction. Once vasoconstriction happens, second, also there will be vasoconstriction of in the glomeruli. Tell me now, which vessels will constrict in the glomeruli? Can't constrict, glomerular capillaries. So who will constrict? Arterioles. Afferent or efferent? Afferent arteriole. So there will be vasoconstriction of afferent arterioles. Vasoconstriction of afferent arterioles. Also parallelly, what will happen now? Okay, we'll write one more arrow mark. Okay, vasoconstriction of afferent arteriole. Can you tell me now? Afferent arteriole is the one which brings blood into the glomeruli or takes away from the glomerulus? Away from the glomerulus is efferent. Why we are vasoconstricting afferent? Because you don't want to lose more blood, isn't it? So afferent arteriole, not efferent. Okay, afferent arterial vasoconstriction, this will lead to reduced GFR. Simple understanding. Vasoconstriction of afferent arteriole, blood supply to the glomerulus reduces, blood supply reduces, GFR reduces. Simple. Now, if the GFR reduces, tell me now what will happen? GFR reduces. Yes, first thing will be, there will be increase in BUN and increased creatinine. Why increase burn in and increase creatinine? Filtration of the glomeruli is reducing. Urea doesn't get filtered. Creatinine also doesn't get filtered. Simple. So increase burn, increase creatinine. This is what we call biochemically azotemia. So what is azotemia? Increased creatinine, increase in urea happening. Azotemia, right? Yes, azotemia. Next is your one more. Sir, if there is a reduced GFR, can you tell me now? Urine output will be more or less? Urine output will be more or less? Anybody? GFR is reduced, urine output will be what? Less urine output. This will lead to oliguria. This will lead to oliguria. I hope all of you are understanding. What is oliguria? Reduced urine output. Next, third one more. Because of reduced GFR, or you can say vasoconstriction of afferent arteriole. When afferent arteriole gets vasoconstricted, blood supply to the glomerulus is more or less. Blood supply to the glomerulus is less. Very, very important. Kidney can sense both oxygen and volume. Remember, kidney can sense both oxygen and volume and can compensate. If it senses hypoxia, it will compensate by erythropoietin. If it senses hypovolemia, because of vasoconstriction of afferent arteriole, the glomeruli are getting less blood. The patient is not having hypovolemia, but the glomeruli are getting what? Less blood. So your glomeruli sense there is a hypovolemia, isn't it? Yes. So because hypovolemia, how do they compensate? Tell me now. Yes, sir. So there will be activation of renin-angiotensin-aldosterone system. RAS axis gets activated. Renin-angiotensin-aldosterone, RAAS short form you can write. I am just writing renin-angiotensin. What will renin-angiotensin do? Renin-angiotensin-aldosterone will end up retaining sodium and water. And because of sodium water retention, what will happen? There will be sodium and water retention. There will be sodium and water retention. Yes, very good. Sodium and water retention will lead to what now? See, look, patient's blood volume is normal or reduced in this patient. Patient's blood volume was normal and now you have activated RAS, you retain water. So your volume now starts expanding. Volume expands. Tell me what will happen. Volume expands. There will be increased hydrostatic pressure. Hydrostatic pressure increases. Outward movement of water increases. Edema will happen. Understandably. So patients will develop edema. Not only edema, because volume is expanding, blood pressure will also increase. So patient will have hypertension as well. Patients will have hypertension as well. Patients will have hypertension also. Next, one more is your, because of endothelial damage, size-based filtration defect. Size-based filtration defect, this leads to loss of RBC in urine. Loss of cells in urine, RBC, hematuria. And of course, there will also be RBCs while going through the tubule will end up having what? RBC cast. So hematuria here will be what? RBCs will be there and RBC cast will be there in urine. Isn't it? So RBC and RBC casts in urine. This is what you will see in, and this is what we call it as acute nephritic syndrome. Clinically, acute nephritic. So acute nephritic, simple for me. Pathologically, what do you mean by acute nephritic? Pathologically, acute nephritic means there is an injury happening to the mesangium or what? Endothelium, right? That is what is acute nephritic. Now the problem is the same disease can have a nephritic or also nephrotic, depends upon what? The charge of the immune complex. Like lupus is one where there are many antigens, because in loop antibodies are many. It is what? There are so many anti-dsDNA, anti-histone, anti-Rho antibodies, so many anti-Smith antibodies. All these antibodies cannot form what? Same immune complexes, because the antigen is what? Different. Because antigen is different, the charge and the size of the immune complex will be different. Now, in a patient, there might be more than 2 antibodies also, like anti-Smith, anti-Rho, anti-dsDNA, everything is there. Then what? Multiple immune complexes of multiple charge will be there. That is the reason why there will be, we better call the diseases as what? Predominantly nephritic and a predominantly nephrotic. Why? Same disease can have both nephritic as well as what? Nephrotic. We'll come to know what is a nephrotic. Isn't it? Yes. So this is what is your nephritic syndrome. Now important, this acute nephritic syndrome, what happens to this acute nephritic? If damage is severe, what will happen now? Tell me. If damage is severe and persistent. So your vasoconstriction also becomes very persistent. If the vasoconstriction becomes very persistent, can you tell me, this will lead to the acute nephritic syndrome, will lead to now what? Anuria. So there will be anuria. This is nothing but acute renal failure. Acute renal failure. So acute renal failure is nothing but a complication of acute nephritic syndrome. And when will that happen? That will happen. No, this is not CKD. This will be ARF, acute renal failure. That will happen if the damage is what? Very severe and persistent. It should persist for a prolonged duration. If the damage was transient, then your kidney will what? Will come back to normal. And this is what we call it as now what? So these glomerulonephritis, which are having severe damage, they progress to what? Acute renal failure. These are called RPGN clinically. What is RPGN now? Tell me. Rapidly progressive glomerulonephritis. So RPGN is a complication of an acute nephritic syndrome. RPGN is a complication of an acute nephritic syndrome. So now logical think, in PSGN, where there is an implanted antigen, implanted means the antigen is coming from outside. So can there be RPGN happening? Less likely to have a RPGN. In IgA nephropathy also less likely to have a RPGN, because immune complexes are predominantly in one? Mesangium. Mesangial deposits will not cause severe vasoconstriction. So on the contrary, all the small vessel vasculitis frequently progress to what? RPGN, because all small vessel vasculitis like lupus, HSP, ANCA associated vasculitis, they progress to what? RPGN frequently. Yes. So I hope all of you are understanding what is an RPGN. RPGN is a complication of acute nephritic syndrome. Acute nephritic syndrome, remember, is one of the clinical manifestation of what? So one of the clinical manifestation of a glomerulonephritis. One clinical manifestation is a nephritic syndrome. Second, we also say is what? RPGN. So in RPGN, basically what? Patient initially presents with nephritic syndrome and will progress to what? Renal failure. Isn't it? Yes. Acute renal failure. Next is effacement of food processes. Another pathology, let us discuss. So if there is effacement of food processes, or there is loss of food processes, or loss of filtration slit proteins. Tell me now, if there is a loss of filtration slit protein, it can be a congenital loss like what? Nephrin podosin deficiency. Congenitally, nephrin podosin are deficient, same problem. Or immune complexes get deposited on which surface now? Subepithelial. Remember, this will be subepithelial. Earlier we discussed subendothelial and mesangial. So this will be what? Subepithelial deposit. Because if there is a subepithelial deposit, then there will be what? Effacement of food processes. I hope all of you are understanding. Yes. Now, if there is effacement, there will be loss of charge-based filtration. Simple. Loss of charge-based filtration. Why? Because if filtration slit was important in one? Charge-based filtration. This will lead to albuminuria. So there will be loss of albumin. There will be no loss of RBC. Albuminuria, and also there will be loss of antithrombin 3. Because antithrombin is also what? Antithrombin is also what? Negative charge. So loss of antithrombin 3 in urine. Antithrombin, yes, we know this, it is a physiological anticoagulant. So if you lose this, there will be thrombosis. Commonly these patients will have renal vein thrombosis, but any thrombosis can happen. Next, if there is albuminuria, tell me now what? Albuminuria is happening. This will lead to, you keep losing albumin in urine, there will be hypoalbuminemia. Hypoalbuminemia. So can you tell me, if you lose albumin in urine, what will happen? Hypoalbuminuria, hypoalbuminemia. If there is hypoalbuminemia, this will lead to decrease in oncotic pressure. Plasma oncotic pressure reduces. Anybody remembers? Yes, of course, any thrombosis can lead to, if it is on the left side, it can lead to varicocele. So varicocele also, yes, nothing wrong with that. There can be varicocele. In fact, there can be edema in the testis. Scrotal edema also can happen here, by the way, right? So now there is a reduced oncotic pressure. Now look, if there is a reduced oncotic pressure, then what? Reduced oncotic pressure leads to reduced influx of water into the venules. See, oncotic pressure, hydrostatic pressure was what? doing an outward movement of water, and oncotic was bringing the water back into the venules, isn't it? Now, because oncotic is reduced, outward movement is normal because hydrostatic is normal. Inward movement is not happening. Because reduced influx of water in the venules, this will lead to one, water will be left behind in the tissue, that will lead to increased fluid in the tissue, that is edema, by the way. Understandable? Now, more important than this is, if influx of water in the venule is less, can you comment upon intravascular volume in the venule side? Tell me now, what is happening to the intravascular volume in the venous side? Intravascular volume is decreased. Decreased blood volume in the venous side. It is not like a shock. Don't get confused. So there is a slight decrease in the blood volume. It is not as good as what you have got what? Shock. Now, so because there is reduced blood volume, so now tell me, if the blood volume is less, so kidney will get more or less? Kidney will get less. So because kidney are getting less, renal hypoperfusion happens. Now look, so renal hypoperfusion, should there be activation of RAS again? Yes, very good, absolutely, you're right. So there should be activation of renin, angiotensin, aldosterone system. So RAS activation. Can anybody tell me, once your RAS gets activated, tell me now what will happen? RAS activation. Once your RAS gets activated, RAS will retain sodium and water. Yes, when sodium and water retains, can you tell me now, the volume before activation of RAS was more or less or normal? Now look, difference here only you identify. In a nephritic also RAS got activated, correct? But in a nephritic, the volume before RAS activation was normal. Why RAS got activated then? Because volume was normal, but why RAS got activated there? Because of glomeruli were hypoperfused, because of vasospasm of the afferent arteriole, isn't it? Yeah. So here volume is less. So there volume was normal. Volume in nephritic, volume was normal. You activated RAS, you added more volume. That's why volume became more, hypertension. Here volume is less. Because volume is less, now look, very important, volume is less. You add sodium and water, volume becomes normal. Volume doesn't exceed. Volume becomes normal. So this converts your what? Normal volumic. Blood becomes normovolumic. Because blood is becoming normovolumic, hydrostatic pressure and BP will become normal. They cannot increase. So important, no hypertension here. Next, not only that, let me talk further. Because the blood has become normovolumic, your hydrostatic pressure has become what? Normal. So very important. Look, if the RAS did not get activated, let me explain you what would have happened. If the RAS did not get activated, kidney would not have retained water. Yes, correct. If the kidney would not have retained water, volume would be low. Volume is low, hydrostatic pressure would have fallen. If the hydrostatic pressure had fallen, outward movement would have what? Reduced. Understandably. So if the hydrostatic pressure would have fallen, outward movement would have reduced. Simple. Why? Because hydrostatic pressure is the one which is what? Moving outwards. Outward movement reduces, edema would have become more severe or less severe? Tell me now. Yes, edema would have become more severe or less severe? If RAS did not get activated, edema would have been very less severe here. Why? Why more severe edema? We'll understand now. Because there is a normovolumia, your hydrostatic pressure becomes normal. Hydrostatic pressure becomes normal, outward movement becomes normal. Outward movement has become normal, so kidney corrected hydrostatic pressure. Absolutely good. But kidney couldn't correct oncotic. Kidney couldn't correct oncotic. So that is why water goes outside, it doesn't come back again. So again, if it doesn't come back, then again there will be what? More fluid left in the tissue. And again there will be what? Less blood in your intravascular volume. Again you activate RAS. Again what? So there is a vicious cycle of RAS activation. So if they ask you, RAS activation is more severe in nephritic or nephrotic? Important, they will ask this question. RAS activation is more severe in which condition? Nephritic or nephrotic? RAS activation is more severe in nephrotic, not in nephritic. It is more severe in nephrotic. But despite so much of activation of RAS, there is no sodium, there is no hypertension here. There is no hypertension. Why? Blood volume is not exceeding. And that is why, okay, basically I mean to say, whatever water you are retaining, whatever your kidney is retaining, all that water is lost into the tissue. And that is the reason why edema is generalized edema in nephrotic. And this is called anasarca. This is called anasarca. So patients here, are having thrombotic manifestations and anasarca. Next, one more. Now look, very important, when oncotic pressure is reduced, your liver was the one which was producing what? Albumin. And now liver gets a feedback that my oncotic pressure is reducing, try to do something. Yes, try to do something. So when I try to do something, meaning what? I have to try to produce more what? Liver tries to produce more albumin, but no matter how much albumin liver produces, it will all be lost in urine. So now liver has to produce some other protein which can have some oncotic activity, but they should not be lost in urine. So this eventually leads to now what? A positive feedback to the liver, and the liver starts producing some other protein. I told you it has to produce a protein which should try to exert some osmotic activity and should not be filtered by your what? Glomeruli in the urine. This is your hepatic lipoprotein synthesis. So lipoprotein will be more synthesized. Why lipoprotein will be more synthesized? Because any protein your liver wants to produce. Hepatic lipoprotein more hepatic lipoprotein. So there will be, I'll write increase here, hepatic lipoprotein. So if there is increased hepatic lipoprotein synthesis, can you tell me now? This will lead to what? Increased hepatic lipogenesis. This will lead to hyperlipidemia, which eventually leads to lipiduria also. Which will lead to lipiduria. So this is your nephrotic syndrome. This is your nephrotic syndrome. So I hope all of you are now understanding what is a nephritic and what is a nephrotic syndrome and what is a RPGN. These are the three primary clinical manifestations of glomerulonephritis. Yes, of course, because of lipiduria, there will be fatty cast seen. Whereas you were seeing what cast in glomerulonephritis? Yes, you are seeing what? In nephritic syndrome, you are seeing what? So now, let me ask you, let me just clarify all the doubts here. Tell me now, glomerulonephritis will show fatty cast or RBC cast? Tell me now what is the correct answer. Glomerulonephritis shows fatty cast, RBC cast, can show both. Option A, B, C. Tell me now. Glomerulonephritis will show which cast? Fatty cast, RBC cast, both. Glomerulonephritis will show which cast? Fatty, RBC, both. Glomerulonephritis will show which cast? It can show both casts. Remember, don't get confused. A glomerulonephritis manifesting as a nephritic will show what? RBC cast. One which is showing nephrotic will show what? Fatty cast. Some disease can have both also, by the way, right? Yes. So let me take one question here then. So let me look at one of the question. Oops, the image hasn't come. Okay, yes. So let us look at this question now. What is this question? Okay, I'm taking two questions. Let me try to solve. Okay, 42-year. Okay, last line always. I always start in a question. Start with your what? Last line. It is easier. What is a likely pathogenesis in this patient? They have given an image. Don't go to the image. Options. Inherited deficiency of alpha 3 chain of type 4 collagen. This will be what? Alport syndrome, if you remember. C-ANCA, okay, C-ANCA mediated vasculitis, immune complex mediated disease, many immune complex mediated, type 2 hypersensitivity, in kidney is only one, good pasture syndrome, right? Yes. So let me see now, what is the question? Oh, very good, very good. What you are seeing here, immunofluorescence, I showed this image, this is your what? Linear deposit. So if you are seeing linear deposit, only one diagnosis. What is your diagnosis? Good pasture syndrome, right? So answer is option D. Option D. True, they have asked. Answer will be what? Option D here. Yes, very good. This is a good pasture syndrome. Anyway, so let me just look at the question. 42-year lady presents with easy fatigue, breathlessness. She is unable to perform routine morning walks despite quitting smoking. BP 140, 88. Look at this. Hypertension is there. Hypertension. Respiratory rate. Then urine examination. RBC cast. Definitely now one. Acute nephritic. I am thinking of what? Nephritic. Isn't it? Proteinuria is also there. 1+. Not significant. A renal biopsy was performed. And this is what you are seeing. This is your what? Good pasture syndrome. Very good. Good pasture. Linear deposits. Next, let us see the next question. Yes, sir. Tell me now. A child presents with periorbital edema, facial puffiness and ascites. Urine examination 3+ proteinuria, serum albumin 2.5. grams per liter. Tell me now, what is it? Which of the following is true about the disease they have asked? Tell me, what is true about the disease? Yes, RBC cast in urine, false. Why? Because this is clinically nephritic or nephrotic. Nephrotic. So RBC cast will be what? False. RAS activation, yes, that is true. Hypertension, false. ARF is a frequent complication, true or false? False. ARF is a frequent complication of acute nephritic, not nephrotic. Nephrotic, GFR doesn't reduce, that's why no azotemia in nephrotic. Nephrotic will not progress to ARF. Nephrotic will not cause what? Acute renal failure. In fact, clinically this will be a minimal change disease. Yes. And RAS will be more severely activated in nephrotic as compared to nephritic. Right? So I hope all of you guys understood the concept of the glomerulonephritis. No need of mugging of all the glomerulonephritis now. You just have to need to remember what. So in every glomerulonephritis, start just remembering what? Where are the deposits? Now we can understand why EM is so important here. Where are the deposits? That will tell you the clinical feature. You need not mug up the clinical feature. Forget about the clinical feature. Like, let me give you an example. Okay, what is the EM finding of minimal change? Loss of or effacement of food process, nephrotic. What is the EM finding of MGN, membranous glomerulonephritis, subepithelial deposit, manifestation, nephrotic. What is the EM finding of MPGN, subendothelial deposit, primarily nephritic. What is the manifestation of PSGN? PSGN initially in the disease subendothelial will be there. They migrate to subepithelial later on. So because initially in the disease they were subendothelial, again what? Nephritic. IG nephropathy. Deposits are seen in the mesangium. That is why nephritic. Now important, remember, any glomerulonephritis, if it keeps recurring, what will happen? Fibrosis will happen. When fibrosis happens, there will be ultimately effacement of food processes, because fibrosis will end up leading shrinkage of cells, and that is when they will lead to nephrotic. Like a IG nephropathy, if recurrence, there will be fibrosis and can progress to what? FSGS. What is FSGS? Focal segmental glomerulosclerosis. Because of sclerosis, the effacement of food processes is happening. Again, they will also manifest as nephrotic. I hope all of you are understanding this point. Simple. So all that you have to remember is what? Where are immune complexes getting deposited? This is, you have to mug it up. And some diseases like lupus, very wide manifestation. There can be a subepithelial deposit, and that can lead to minimal change disease. There might be a subendothelial deposit. Yes, there might be a basement membrane deposit. So deposits can be anywhere in certain diseases, right? Yes. So I hope all of you have now developed the concepts. With this, your glomerulonephritis in medicine pathology should become easy. I keep telling this, if you are young, second, third year student listening to me, your pathology should be your strongest. Medicine, sote bhi aayega aapko. If you do pathology well, if you understand pathology well, I need not read medicine. I keep saying this. Robbins is one book, you know them. I mean, the concept of the Robbins, if you have understood, then you will end up what? Remembering everything. Full house effect, we call it in lupus. Lupus full house effect, especially in type 4 lupus, where all antibodies are deposited. IgG, IgA, C1, C3, everything is deposited. That's called full house effect. And if you are a current intern, post-intern also, doesn't matter. If you are not good at pathology, then you will start finding difficulty with what? Medicine. So, har bar you will keep telling what? I'm not understanding, I'm not understanding. Okay. You have to understand, then it will be what? Pathology. GPS antibody will be against, alpha 3. GPS antibody will be against alpha 3. In Alport, there can be deficiency of alpha 5 predominantly. Even alpha 3, alpha 4 are also deficient in Alport. Any doubts, guys? Any doubts? Alport predominantly alpha 5. Even alpha 3, alpha 4 are reported. Alpha 5 is X-linked Alport. Alpha 3, alpha 4 are autosomal Alport. 15% of Alport are due to alpha 3 and alpha 4. Okay, class on hypertension sensitivity, I will take it, don't worry. Treatment of lupus, I don't want to get into that. Treatment of lupus, they will be discussing in medicine. obvious logic is what? Immunosuppressives have to be given. That is the basic idea. Basic idea I can give you. Okay. Bye guys. So best wishes all of you.